It's funny how we categorize conversations about aging. Like, if you walk into a crowded room and complain about a hot flash, you'll probably get sympathetic nods from everyone.
Oh, absolutely. Everyone chimes in.
Right. People will immediately share their, favorite cooling fan recommendations or which breathable fabrics to buy. That part of menopause is just entirely public now.
Yeah, it's completely
Oh,
normalized,
great.
which is great, but
But if you try to bring up the physical changes happening further down, like the vaginal dryness, the pain, or those recurrent urinary tract infections, suddenly, I mean, the room just gets very, very quiet.
it really does. It remains this ultimate taboo. We've completely normalized the visible outward symptoms, right? Yet the invisible changes, the ones that profoundly impact intimacy and daily comfort and, well, just fundamental bodily functions, they're still spoken about in hushed whispers.
If they're spoken about at all.
Exactly, assuming they're spoken about at all.
And that silence is exactly what we are breaking today in this deep dive. I am so glad you were joining us for this, by the way, because we're looking closely at a condition that affects roughly 50% of postmenopausal women. 50%.
It's a staggering number, half the population.
Half. And despite that, so many just suffer through it in silence, assuming it's just this inevitable, normal part of aging that you just have to put up with.
Which is such a tragic misconception. I mean, truly. The medical terminology has actually evolved over the last decade or so to better capture the reality of this condition.
Because it used to just be called vulvovaginal atrophy, right?
Right, vulvovaginal atrophy.
Which sounds terrible, like something's just withering away.
It really does. It's very bleak. But now it is officially known as genitourinary syndrome of menopause, or GSM. And that name change is vital because it recognizes that this isn't just, a vaginal issue. It is a comprehensive syndrome affecting the entire urinary and genital tract.
Okay, so today we have a very specific mission for you listening. We are pulling from a massive stack of the latest clinical guidelines. I mean, we've got the British Menopause Society, the National Institute for Health and Care Excellence, or NICE, the American Urological Association, plus a bunch of patient leaflets and major clinical reviews.
That's a lot of dense material.
It is. And we're going to use it to put the two heavy-hitting treatments for GSM head-to-head. So on one side, we have topical vaginal estrogen creams and inserts. And on the other side, we have a newer, highly innovative treatment, which is vaginal DHEA inserts.
But this deep dive goes far beyond just picking a winner. We're going to demystify how these treatments actually work at a cellular level.
Yes, the biology of it is fascinating.
It really is. We want to separate the lingering, scary myths of systemic hormone replacement therapy from the biological reality of local treatments. Because ultimately, the goal is to equip you with the knowledge to understand exactly what is happening inside your own body.
Exactly. Whether you are navigating these changes yourself right now, or, you want to be an informed partner, or maybe a supportive friend to someone who's struggling, understanding these options can completely transform a person's quality of life.
It's life-changing information.
It really is. But before we can genuinely compare the treatments, we need to understand the battlefield itself. So what is GSM actually doing to the pelvic region?
Well, to truly grasp the impact of GSM, we have to look at the role estrogen plays before menopause.
Okay.
Estrogen is essentially the primary fuel source. It keeps the tissues of the vulva, the vagina, the urethra, and the bladder thick, elastic, and richly supplied with blood.
Right. It keeps everything healthy and plump.
Exactly. And furthermore, estrogen maintains a very specific acidic environment in the vagina. We're talking typically a pH between 3.5 and 4.5.
I was reading about that pH balance in the guidelines, and the mechanism is it's wild. The estrogen actually causes the vaginal cells to produce glycogen, right?
Yes, glycogen is key here.
And then the healthy bacteria in the vagina, the lactobacilli, they basically feed on that glycogen and produce lactic acid as a byproduct.
You've got it. That lactic acid acts like a natural defense system. It creates an environment that is far too acidic for harmful bacteria, like E. coli, to survive in.
So it's like this perfectly balanced, self-sustaining ecosystem.
It is a perfect ecosystem.
Yeah.
But during perimenopause and menopause, that estrogen fuel line basically gets cut off. So without estrogen driving the production of glycogen, the lactobacilli starve.
Oh, wow. So the good bacteria just die off.
Exactly. And when they die off, the pH level rises. It becomes less acidic. So suddenly, that natural defense system completely collapses, and the area becomes highly susceptible to harmful bacteria.
Which is why recurrent urinary tract infections become such a massive problem for women going through this.
Precisely. The protective shield is gone. And along with that bacterial shift, the physical tissues are undergoing a dramatic structural change too.
Right, because without the estrogen, the tissues become noticeably thinner. I mean, they lose their elasticity, the blood flow decreases, and the natural lubrication just, well, it dries up.
The structural degradation is profound, really.
Right.
The epithelium, which is the surface layer of cells, shrinks from this thick, robust barrier down to just a few layers of incredibly fragile cells.
You know, the analogy that kept coming to my mind as I was reading the clinical descriptions was a kitchen sponge.
Oh, I like that. How so?
Well, think of healthy, estrogen-rich vaginal tissue like a damp, plump kitchen sponge. It's bouncy, it's flexible, and it can handle a lot of friction without taking any damage.
Right, it gives.
Yeah, but GSM turns that tissue into a sponge that's been left out on the counter in the sun for like a week. It dries out entirely, it loses its bounce, and it becomes incredibly brittle. And if you rub a dry sponge...
Doesn't glide.
Exactly, it doesn't glide, it snags and it tears.
That is a perfect analogy. And that brittleness translates directly into the physical symptoms.
Mm-hmm.
When you have tissue that is structurally compromised, like a dry sponge, everyday friction causes microscopic tearing.
Ouch.
Yeah, and this leads to the classic symptoms of GSM. We're talking chronic dryness, a constant burning sensation, intense itching, and dyspareunia, which is the medical term for severe pain during sex. The tissue simply cannot handle the mechanical stress of intimacy anymore without sustaining microtrauma.
But a huge misconception is that GSM only matters if you're sexually active. Yeah.
Oh, absolutely. That is a huge myth.
Because the bladder and the urethra are also just densely packed with estrogen receptors. So when they're starved of estrogen, they atrophy right alongside the vaginal tissue.
They're all connected. It's the same ecosystem.
Right. And so women with GSM often experience urinary frequency, like this intense urgency to pee, and those terrible recurrent UTIs we mentioned. I mean, it can make simply sitting at a desk or going for a walk or just wearing a pair of jeans incredibly painful.
It affects everything. And what is most crucial to understand, and I mean, this is emphasized across all the clinical guidelines we looked at, is the trajectory of this condition.
Because it doesn't just go away.
No, it doesn't. Unlike vasomotor symptoms like hot flashes, which might eventually fade away as the body adjusts to the lower hormone levels, GSM is a chronic, progressive condition. It does not get better on its own.
Wow.
Yeah, without intervention, the tissue just continues to thin out, and the symptoms generally just worsen over time.
Okay, so we have this dried out, brittle sponge starved of estrogen. The most logical first step, and really the reigning champion of treatments for decades, has been to just put the estrogen back right where it belongs. Enter topical vaginal estrogen.
Topical estrogen is undeniably the gold standard. It utilizes either estradiol or estriol, and it comes in several different delivery systems to suit whatever the patient prefers.
Right, so there are creams, like Avestin, which you apply with a specialized applicator.
Yep. And there are tiny vaginal tablets or pessaries like Vagifem. There are even these flexible silicone rings like Estring that a doctor or patient inserts into the upper vagina, and it just slowly releases a steady dose of estrogen over 90 days.
Which is so convenient, and because it's applied directly to the affected tissue, it bypasses the digestive system and works locally to reverse all those changes we just talked about.
It does. It signals the blood vessels to expand, bringing oxygen and nutrients back to the pelvic floor. It restores the thickness of the epithelial cells, essentially, plumping that sponge back.
Plumping the sponge?
Exactly. And crucially, it restarts the glycogen production, which feeds the lactobacilli, drives the pH back down, and shuts out the harmful bacteria causing the UTIs.
So it just completely reboots the ecosystem.
It is remarkably effective at repairing the entire genitourinary ecosystem, yes.
But here's where we run into a major psychological roadblock for a lot of patients. You hear the words estrogen and hormone therapy, and immediately alarm bells go off.
Oh, the fear is very real.
I mean, we've all seen the terrifying headlines. Back in the early 2000s, the Women's Health Initiative study published findings linking systemic HRT to increased risks of breast cancer, blood clots, strokes.
It scared an entire generation of women away from hormones.
Completely. So if someone is putting estrogen directly into their vagina, aren't they absorbing it into their bloodstream and taking on all those systemic risks?
I'm so glad you brought this up. It is the single most common fear patients express when this treatment is suggested. Those early headlines left a deep scar on the public consciousness regarding hormone therapy.
Right.
But we have to draw a massive impermeable line between systemic HRT, like taking an oral estrogen pill, or wearing a high-dose transdermal patch that circulates hormones through your entire bloodstream and local vaginal estrogen.
Yeah, and the clinical data from the British Society of Sexual Medicine really puts the difference in scale into perspective. Listen
Yeah.
to this. If a woman uses a standard 10 microgram vaginal estrogen pessary regularly, twice a week, for an entire year.
A whole year of treatment.
Yes. The total amount of estrogen her body absorbs systemically is equivalent to taking just one standard 1 milligram oral HRT tablet.
One single pill spread across an entire year of treatment.
Wait, really? Just one pill?
Yes. The systemic absorption of vaginal estrogen is practically negligible. It stays exactly where you put it.
That's incredible.
Now, I should note, there's a very slight initial peak in absorption during the first week or two of use. Because the vaginal tissues are so thin and damaged and covered in micro tears at the beginning, a tiny bit more estrogen slips through into the bloodstream.
That makes sense. The barrier is broken.
Exactly. But once the tissue plumps up and heals, it creates its own robust barrier again. And from that point on, systemic absorption drops to essentially zero.
Wow. And because the systemic absorption is so incredibly low, the clinical guidelines, including those from NICE, explicitly state that you do not need to take a progestogen alongside vaginal estrogen.
And that is a critical distinction for patients to know. With systemic HRT, you must take a progestogen to protect the lining of the uterus. Systemic estrogen can cause the uterine lining to thicken, increasing the risk of endometrial cancer.
But local doesn't do that.
No. Vaginal estrogen doses are so microscopic and stay so localized that they just don't reach or stimulate the uterus. Therefore, it doesn't increase the risk of endometrial overgrowth. It's proven safe for long-term use.
And it actually requires long-term use, right? Because if you stop applying it, the tissues will just eventually revert back to their dry, atrophied state.
Sadly, yes, it's a maintenance therapy.
Okay, so we have a treatment that is safe, effective, repairs the tissue structure, and virtually eliminates menopausal UTIs. I mean, it sounds like an absolute miracle cure.
It's fantastic for a lot of women.
Right. But if topical estrogen is that spectacular, why do the guidelines even present another option? Like, why are we pitting it against something else?
Because medicine is never one size fits all. Different bodies require different mechanical solutions. While estrogen is fantastic at rejuvenating the surface lining of the vagina and the bladder lining, the vaginal wall is a highly complex structure.
It's not just the surface.
Right. Beneath that surface lining, there are deeper muscle layers and a dense network of collagen fibers that also atrophy during menopause. So some women diligently use topical estrogen, and their surface tissue looks perfectly healthy to a doctor, yet they still experience deep, severe pain during intercourse.
And this is exactly where our innovator enters the arena. Vaginal DHEA, which is widely known by its prescription brand name, Intrarosa.
Yes, Intrarosa.
Now, the medical literature refers to this as an intracrine treatment. When I first saw that word in the sources, I had to stop and look it up because it just completely flips our traditional understanding of hormone therapy on its head.
Intracrinology is a fascinating field.
It really is. So DHEA, which stands for dehydroepiandrosterone, is naturally produced by your adrenal glands, right?
Correct. However, DHEA itself is entirely inactive. It does absolutely nothing on its own.
Okay.
It is merely a precursor. It's a raw biological material. And as we age, our natural production of this raw material plummets.
And the thing that completely blew my mind in the sources is that when you insert this inactive DHEA into the vagina, it doesn't act like a hormone in the bloodstream at all.
No, it doesn't.
Instead, it enters directly into the vaginal epithelial cells. And once inside the cell, specific localized enzymes take that DHEA and convert it into active estrogens and active androgens, specifically testosterone, right there on the spot.
Yes. The enzymes inside the individual cells act like these specialized manufacturing plants.
When trying to wrap my head around this mechanism, I realized it is essentially like delivering a flat-pack IKEA box to a house.
Oh, I love that comparison.
Right. Like systemic HRT is like trying to shove a fully assembled massive couch through the front door of your house. It bumps into the walls, it affects the whole hallway, and there are systemic risks involved in forcing it inside.
And topical estrogen.
Topical estrogen is much better. It's like carrying a pre-assembled chair directly through the patio door into the living room where it belongs.
And DHEA is the flat pack box left on the doorstep.
Exactly. You drop the DHEA box at the doorstep of the vaginal cell. The cell pulls the box inside, opens it up, reads the assembly instructions, which are those specific enzymes you mentioned, and uses the raw materials to build exactly the furniture it needs.
Right inside the cell.
Yeah, it builds estrogen and testosterone right there inside the cell. And the best part is, no fully assembled furniture ever spills out into the neighborhood bloodstream.
The clinical science validates that analogy beautifully. That localized assembly process is the defining characteristic of endocrinology. The conversion to active hormones happens entirely inside the cell.
Which is just so cool.
It is. And here is the most remarkable part of the data. 95% of those newly built active hormones are deactivated and broken down right there at the site of synthesis.
Wait, so they never leave the cell?
Nope. They do their structural repair work within the cell, and then they are dismantled before they can ever cross into the general bloodstream. Long-term clinical trials tracking patients on vaginal DHEA for 52 straight weeks demonstrated zero significant increase in their overall serum estrogen or testosterone levels.
So you get the profound benefits of the hormones with virtually no systemic exposure.
Exactly.
Okay, let's look closer at the actual furniture being built inside that cell. We already know what estrogen does, but the IKEA box also builds testosterone. Why on earth does the vagina need testosterone?
This represents the unique targeted advantage of DHEA. Estrogen is excellent at thickening that surface lining and restoring the acidic pH like we talked about.
Right.
But those local androgens, the testosterone molecules, they penetrate much deeper into the tissue architecture. They target the stromal compartment.
Okay, the what compartment?
The stroma. It's the deeper connective tissue. The testosterone stimulates the fibroblasts, which are the cells responsible for producing collagen. It actively improves the density, compactness, and physical strength of the collagen fibers within the vaginal wall.
Oh, wow. So it is literally rebuilding the deep structural integrity of the sponge, not just wetting the surface.
Precisely. For women dealing with severe dyspareunia, where the pain isn't just about a lack of surface lubrication, but stems from a deep, fundamental loss of tissue elasticity and muscle tone, that localized testosterone production can be the critical missing element that completely restores sexual comfort.
Okay, so we have the established champion, topical estrogen, and this incredible intracrine innovator, DHEA. Let's put them in the ring together for a practical showdown.
Let's do it.
If you are sitting in your doctor's office staring at these two prescriptions, how do you actually make the choice for your daily life?
Well, the decision almost always comes down to the practicalities of application, the specific symptoms that are ruining your day, and your personal budget.
Yeah, that makes sense. Let's examine the dosage schedules first, because they are quite different.
Very different.
With vaginal estrogen, you typically start with a loading phase. You insert the cream or the tablet every single day for about 2 weeks to aggressively wake up the starved tissues. But after that initial phase, you drop down to a very manageable maintenance dose of just twice a week.
Right.
Or if you opt for the S-string, you have a doctor insert it once and you don't even have to think about it again for 90 days.
By contrast, Intrarosa, the DHEA insert, requires a daily application at bedtime. Every single night. Indefinite.
Every night.
That's a lot. It can be. For some women, brushing their teeth and using an insert becomes a seamless nightly habit. But for others, the mental load of remembering a daily insert is just exhausting compared to a simple twice-weekly estrogen tablet.
Definitely. And we also have to talk frankly about the mess factor. Our clinical sources do not shy away from this at all.
It's a very practical concern.
Yeah, I mean, estrogen creams can obviously be a bit messy to measure and apply, but the DHEA inserts have a very specific formulation issue. They are suspended in something called a hard fat base.
Yes. The DHEA is formulated inside a solid, bullet-shaped lipid base that is designed to melt completely at body temperature, thereby coating the entire vaginal wall with the precursor material.
But the inevitable consequence of physics is that what melts inside must eventually come out.
It always does. Women using DHEA frequently report a noticeable waxy vaginal discharge the next morning. It is completely medically harmless. I mean, it is literally just the delivery vehicle melting away. But it is a practical reality you have to manage, usually by wearing a panty liner every day.
Okay, so if DHEA is this incredible flat-pack delivery system that magically gives the cells both estrogen and testosterone with zero systemic absorption, why isn't it just universally prescribed? Why deal with standard estrogen at all?
That's a great question. The clinical guidelines heavily favor topical estrogen for two major reasons.
Yeah.
Decades of safety data and, most importantly, urinary symptoms.
Ah, the UTIs.
Exactly. Topical estrogen has been studied extensively for generations. It is exceptionally well proven, generic versions make it incredibly cheap, and it is widely accessible at any pharmacy. DHEA is a much newer drug on the market. There are no generic equivalents yet, and it can be prohibitively expensive depending on your insurance coverage.
And the urinary aspect is a massive differentiator, isn't it? Because the lower bladder, the trigone, and the urethra are absolutely packed with estrogen receptors.
They are. And because topical estrogen has been the standard of care for so long, there are mountains of robust clinical evidence proving that it dramatically reduces urinary frequency and prevents recurrent UTIs.
Whereas DHEA.
DHEA simply does not have that same level of evidence for the urinary tract. It is primarily licensed, studied, and proven for treating dyspareunia and vaginal dryness. If your primary, most debilitating symptom is a constant feeling of an impending UTI, topical estrogen is unequivocally the superior choice.
Okay, that makes it pretty clear. Now, while looking through the guidelines for both of these treatments, I noticed a very prominent warning to patients about an adjustment reaction.
Oh, yes.
It seems a lot of women start these treatments, experience intense burning, assume they are having a severe allergic reaction, and immediately throw the medication in the trash. What exactly is happening biologically there?
It is a heartbreakingly common scenario, honestly. When the vaginal tissue is severely atrophied, the protective epithelial layer is almost entirely gone.
Right.
This leaves the microscopic nerve endings, the nociceptors, completely exposed. Furthermore, the tissue is covered in tiny, invisible microtears.
So if you have a paper cut on your finger and you rub lotion into it, it stings like crazy, even if the lotion is designed to help it heal.
That is the perfect way to understand it. When you first apply either an estrogen cream or a DHEA insert to a landscape of raw, micro-torn tissue with exposed nerve endings, it is going to sting or burn.
It's unavoidable.
It's an inflammatory pain response to a foreign substance, not an allergy to the hormone itself. In the vast majority of cases, if a patient can just push through that initial discomfort, the stinging subsides entirely after a few weeks, once the tissue plumps up and the nerve endings are covered again.
Okay, and a quick, vital, practical note from the sources for anyone relying on barrier contraception. Both estrogen creams and the lipid-based DHEA inserts can severely degrade latex condoms.
Yes, very important.
The oils and fats break down the structural integrity of the latex, making them prone to snapping. That is absolutely something you need to plan around.
A critical safety consideration indeed.
So what does all of this clinical data mean for the most complex medical cases? Because to truly understand the safety profile and microscopic absorption rates of these local treatments, the sources force us to look at how they are managed in the most estrogen-sensitive population on Earth, breast cancer survivors.
This is the ultimate crucible for these treatments. Women who have survived breast cancer, particularly cancers that were estrogen receptor positive, are routinely placed on aggressive medications called aromatase inhibitors, or AIs.
And an aromatase inhibitor is an intense medication. From my understanding of the oncology guidelines, after menopause, your ovaries stop making estrogen, but your body still makes small amounts of it in your fat and muscle tissues using an enzyme called aromatase.
Correct.
And an AI completely shuts that enzyme down, right? It aggressively strips the body of all remaining estrogen to ensure any microscopic dormant cancer cells are starved of their fuel.
It is a highly effective, life-saving strategy for preventing cancer recurrence. But the collateral damage to the pelvic region is catastrophic.
I can't even imagine.
Because they are systematically deprived of even trace amounts of estrogen, these women suffer from the most severe, rapidly progressing, and debilitating forms of genitourinary syndrome of menopause imaginable. Their quality of life can absolutely plummet.
And for a very long time, oncologists and gynecologists were terrified to prescribe any form of estrogen to these patients, even a local vaginal cream.
Right, for fear that a tiny drop of estrogen might enter the bloodstream and wake up a dormant cancer cell.
In fact, if you look at the FDA labels on the boxes for both local estrogen and DHEA right now, they still carry severe black box warnings against using them if you have a history of breast cancer.
Those legacy FDA labels cause immense anxiety. Immense. However, the leading clinical guidelines from the experts, the British Menopause Society, the AUA, and various oncology groups are actively pushing back against the rigidity of those labels.
Because they strongly advocate for shared decision-making.
Exactly.
Meaning a woman shouldn't just be handed a flyer for a non-hormonal moisturizer and told to deal with the pain. She should be able to sit down with her multidisciplinary team to look at the actual modern data.
And the modern data tells a highly reassuring story. Despite decades of observation, no clinical trials have ever demonstrated an increased risk of breast cancer recurrence associated with the use of local, low-dose vaginal estrogen. The absorption is simply too microscopic to impact systemic oncology outcomes.
However, the sources note that for women actively taking aromatase inhibitors, doctors remain incredibly cautious. Because the whole point of the AI drug is to keep blood estrogen at absolute zero.
Absolute zero,
So
yes.
even the microscopic blip in systemic estrogen that occurs during the first 2 weeks of using standard vaginal estriol, like we mentioned earlier, is something they desperately want to avoid. Which brings us back to the different types of estrogen. We mentioned estriol earlier. We really need to distinguish between estradiol, which is the strong, potent estrogen, and estriol.
Estriol, often denoted as E3, is a much weaker, shorter-acting form of estrogen. The critical pharmacological advantage of estriol is that it does not readily convert into estradiol in the bloodstream.
Oh, that's interesting.
Yes. Because of this, specialists will frequently recommend estriol-based products, like the Imvages Pessary or Blissel gel for breast cancer survivors, as it repairs the vaginal tissue without significantly raising the serum estradiol levels that oncologists monitor so closely.
What about our intracrine innovator? Where does the DHEA flat pack fit into breast cancer survivorship?
DHEA is considered a highly preferred premium option in these complex cases.
Really?
Oh, absolutely.
Yeah.
Because of the endocrinology mechanism we discussed, the DHEA is converted to active hormones inside the vaginal cell, it repairs the collagen, and then it is completely deactivated before it ever hits the bloodstream.
That is just brilliant.
It delivers the essential structural benefits of both estrogen and testosterone locally without raising circulating estradiol levels whatsoever. It is an incredibly valuable tool for survivors suffering from severe, intimacy-ending dyspareunia.
I just want to pause for a second and acknowledge how relieving that information must be. I mean, if you are listening and navigating the aftermath of breast cancer, dealing with the brutal, invisible side effects of aromatase inhibitors, you are not simply stuck suffering.
No, you're not.
You do not have to just accept that comfort, intimacy, and a pain-free existence are over for you. There is absolutely room for nuanced, safe, microscopic medical intervention. Your quality of life genuinely matters.
It matters immensely, and it should never be dismissed. No woman should be told that chronic, daily pelvic pain is just the permanent price she has to pay for surviving cancer. The incredibly localized nature of these treatments makes them safe, viable options even in the most highly complex medical situations.
Well, we have covered a tremendous amount of ground today, navigating from cellular biology all the way to oncology guidelines. Let's pull the core message together. What is the definitive takeaway from this massive stack of clinical literature?
The definitive takeaway is that genitourinary syndrome of menopause is not a life sentence.
Thank goodness.
It is a highly understood, deeply researched, and exceptionally treatable condition.
So if you want the established track record, the undeniable protection against recurrent UTIs, and the simple convenience of a twice-weekly dose, topical estrogen is your reigning champion. It fixes the sponge safely, affordably, and effectively.
Exactly. But if you are dealing with profound pain during sex and want the added deep structural benefits of local testosterone building up your collagen without raising your systemic hormone levels, the daily intracrine magic of DHEA is a phenomenal medical innovation.
And the most important action you can take is to advocate for yourself. Start the conversation with your doctor. Stop treating this pain as a shameful secret you just have to endure in silence.
Please don't endure it in silence.
The systemic risks of these local treatments are incredibly low. Do not let the lingering, outdated shadow of oral HRT fears keep you from treating a localized, easily solvable problem.
The tools to repair the tissue exist. You just have to ask for them.
Before we wrap up, there is a fascinating thought experiment I just haven't been able to shake since we started researching the DHEA mechanism. We just learned that our aging vaginal tissues can use an inactive precursor to manufacture their own local hormones on demand, right inside the cell, without spilling anything into the rest of the bloodstream. Endocrinology.
It is an incredibly elegant biological loophole.
It really is. And it raises this wild, futuristic question. What other hidden localized hormone factories might be quietly shutting down in our bodies as we age? Do our brains have these localized assembly plants? What about our skin or our bones?
That is the multi-million-dollar question.
Right, yeah. If they do, could delivering inactive, flat-pack precursor hormones to those specific tissues be the ultimate future of anti-aging medicine? I mean, completely revolutionizing how we treat cognitive decline or osteoporosis far beyond just reproductive health.
If we eventually learn to target the brain or the skeletal system with the exact same cellular intracrine precision we are currently using the pelvic floor, Well, it would fundamentally change the entire landscape of human aging.
It's definitely something to mull over. Until then, remember, you absolutely do not have to accept living with a dried out sponge. The muddy waters of menopause are getting clearer every day. Thanks for joining us on this deep dive. We'll see you next time.